My name is Roland Kroner from the Department of Surgery, University Hospital in Magdeburg, and I want to share with you our learning experience in robotic liver surgery. I have no conflict of interests. For laparoscopic liver resection, an overall learning curve is described for about 45 to 60 cases. In robotic liver surgery, this seems to be much less because recently there was a learning effect described after 30 cases, but currently we don't know the exact volume of patients to overcome the learning curve. In Magdeburg, we established the Magdeburg Registry for minimally invasive liver surgery, where we collect our data from patients which underwent minimally invasive liver resections. I started robotic liver resection in 2013 and switched to Magdeburg in 2017. Since then, we are doing here robotic liver surgery, and we do about 60% of our liver cases minimally invasive now, in a broad spectrum of tumor entities. This is our setting. We use the Da Vinci Xi system. The setting was published already in 2015. We use 6 trocars, 4 trocars for the robot, 1 trocar for the prenatal maneuver, and 1 robot for the assistance at the table. We use ISEG and intraoperative ultrasound for tumor detection and marking the resection margins, and we use several techniques for parenchyma dissection. So we select our patients for robotic liver surgery that there should be no tumor invasion of major vessels, major bile ducts, and there should be no bilateral tumors. We define our liver surgery regarding the Brisbane terminology from 2000, and we use the Ivati severity scoring. To get an idea about the learning curve for robotic liver resection, we screened our registry for surgeons who did more than 50 robotic cases. We were able to identify one surgeon who did 55 consecutive robotic liver resections. The major proportion of the patients suffered from adhesions because for prior abdominal surgery, the BMI was 27. There was 31% which received major liver resections. The major proportion suffered from malignant tumors, and an RCO resection was possibly 95%. The overall morbidity was about 33%, and the liver-associated morbidity 14.5%. There was no liver failure, and there was no mortality in this series. When we screened the consecutive order of the patients, we figured out 3 steps of the learning curves. There was a learning phase 1 where operation time decreased. Here, mainly minor resections were performed, and then the surgeon started major resections. This increased the difficulty score and even the operation time, and then there was a standardization phase where major and minor resections were performed. The operation time stabilized and decreased again. The conversion rate was at the beginning low with 1.8%, then it increased to 7.3%, and during the standardization phase it was 5.5%. In the learning phase 1, 20 patients with Ivati scoring 5.7. In the learning phase 2, 10 patients with Ivati scoring 8.2. And in the standardization phase, 25 patients with Ivati scoring 6.7 underwent robotic liver resection. The QSUM analysis in operation time and also blood loss confirmed our initial findings. When we compared our results with the published literature, where our learning effect was demonstrated after 30 consecutive cases, we were able to confirm these findings in our series. Our study has some limitations because the surgeon was trained in laparoscopic liver surgery before he started robotics. It is an unicentric study with a retrospective analysis and, of course, selected patients. So in conclusion, we can say that robotic liver surgery is safe and feasible. It delivers adequate results for oncological quality. A learning effect can be achieved after 30 cases, but only if the surgeons are trained in laparoscopic liver surgery. So maybe a future concept for the training of robotic liver surgery includes a basic training for robotic liver surgery, then beginning training with IVATE scoring not over 3, and then a second step with a higher IVATE scoring. So thank you for your kind attention, and I would be happy to take any questions.